Yes, sir.
Thank you very much, Manoj, and also the AIOS for the wonderful opportunity. I'm going to talk to you on the next few minutes about perfecting phacoemulsification when combined with vitrectomy, and probably in vitrectomized eyes as well, because Gajendra Chawla is also talking on the similar topic. I thought I'll modify my talk a little bit. As you know, past planar vitrectomy commonly performed procedure. Incidence of cataract is about 70% in 2 years. Unique challenges of cataract in post-PPV eyes. Risk of intraoperative and postoperative complications, dense nuclear cataracts, PSC cataracts, lack of posterior support makes his rexis difficult, zonular weakness, PC tear, removal of the nucleus, epinucleus, cortex complicated because of lack of the vitreous support, fluctuations in the anterior chamber and the posterior chamber as well, iris trauma, choroidal hemorrhage, nucleus drop, and all these complications. You name the complication, it is there in a vitrectomized eye as well. So in PPV changes the structure of the eye. So biometry, optical biometry, more accurate immersion, ultrasound, A scan, B scan, or UBM, you can do, assessing the need for the cataract surgery, preparing the possible complications. Informed consent is very, very important. The silicone oil, as you know, attenuates the sound velocity and axial length of fellow eyes in ideal choice in calculating the IOL power in oil-filled eye. Nowadays, you have the IOL master and the lens start, which gives the silicone mode. So you get the silicone oil thing. Actually, silicone oil acts like a minus lens. So we should add about +3 to +5 diopters to the hemetropic power. And IOL master, lens start, these are the optical biometry. I'm sure everybody is having this nowadays. And it has become a gold standard as far as the IOL power calculator is concerned. Intraoperative protocols, please eliminate hydrodissection or be careful in not doing hydrodissection, less vigorous nucleus manipulation, liberal use of dispersive OVD. I don't have any financial interest. Viscoat is probably the way to go. Clear corneal incision is the way to go. Difficult capsular rexis is difficult due to lack of the posterior support. Poor red reflex, sometimes you can have vitreous hemorrhage. Post vitrectomized eyes also sometimes you can have vitreous hemorrhage. The red glow is not as good as in a normal eye. Trypan blue may be used. Only thing is, if you use a trypan blue, don't use it under air and use a little bit. Don't keep it for a long time. Trypan blue, keep it for a long time. What happens is trypan blue goes inside and produces a blue glow. Instead of red glow, you'll get a blue glow. You can see these sort of cataracts are very, very common. Post-vitrectomy, calcified anterior capsule, you can see the zonule. As soon as you make the rexis itself, you can see the lens is moving around, the subluxation of the lens, the sphecodonosis, which is not very uncommon. And you can see here that I'm using the capsular rexis forceps to make sure that the central fibrotic element is taken care of as well. Again, you can see these sort of cataracts, post-silicone oil patients, the post-vitrectomy patients, very, very fibrotic anterior capsule, calcified anterior capsule. Sometimes you might have to use the vitreous scissors or even the cutter to make sure that you get the capsular rexis right in these patients. Poor red reflex, I'm sure Gajendra is also going to talk about is another major important thing. Use the trypan blue very, very optimally or judicially. Don't use it whizzing. Make sure that because otherwise it's a relatively blind technique. This is a relatively softer cataract. I just popped it up once I did a capsular rexis and did the phacoemulsification. Slow and gentle pre-existing PCR. Please understand these are all vitrectomized eyes. Sometimes number of multiple injections of Avastin Lucentis is given. Be careful of these patients. This is again another patient who had number of injections of Lucentis and dense brown cataract. As soon as my assistant put heavy molecular weight viscoelastic on the cornea, I can see the nucleus disappearing into the anterior, into the vitreous cavity. So this is one of the major problems. Be very, very careful in hydrodissection because there can be a pre-existing PC tear because of the vitrectomy, the lens touch could have been there, or because of the number of injections which are given. Pure pupillary dilatation, rings and hooks. You can use Mulligan ring, or you can use the hooks which are commonly used as hooks, or the Mulligan ring. So there, and it produces less deformity. You can see the BX ring, which is there, which is made by Bhattacharjee, which works very well in these conditions, and it comes through the side port as well. Again, you can see here, this is again a complicated cataract, and combined with the vitrectomy, you can see here how I'm removing the membrane and putting the iris hooks and dilating the pupil as well. So small pupils, sometimes if we don't have anything, you can even stretch the pupil, but I would not suggest this because it pretty makes the pupil very atonic. You can see this is a pupil stretching. Don't do it in the axis of the incision. That is another important point which you have to remember. Deep and unstable anterior chamber, reduce the bottle height. ARIS is acute intraoperative rock hard eye syndrome, managed by halting the irrigation, putting external pressure on the incision to stop leakage. Anterior pressure counteracts the posterior pressure. This is one of the most important because zonules are weak, and the fluid can go behind and push the posterior capsule up. And this is called the ARIS syndrome, which is an infusion deviation syndrome, are not uncommon, especially people who are when they're operating on high myopes with vitrectomized eye as well, because the zonules are weak and the fluid can go into the vitreous and start pushing the posterior capsule up. Again, you can see there's a fluctuation in the anterior chamber as well as the posterior chamber. You can see here, just like the eye fist syndrome, you can see here, as soon as this is because they have the fluid misdirection syndrome pushing the iris up, and as soon as they go inside, the pupil again dilates. And one of the common problems we see vitrectomy because of the lack of the posterior support which is there. Nucleus dismantling vertical chop techniques, less stress on the zonules and the anterior capsule, and PC plaque remove always, because it's very difficult to do YAG laser in these patients because it's a very dense fibrotic capsule, especially post silicone oil. There can be a calcified posterior capsule plaque, which is very, very difficult unless you remove remove this thing. This is just to show you that I make a rhexis. You can see here, this fairly brown cataract. It's very dense cataract, very common post vitrectomy, post oil, and this is very, very common, especially in the older age group. And you can see here how I'm doing the direct chop or the vertical chop technique using the sharp chopper. And just to show you this, this one, another patient with the vitreous hemorrhage, I think, yeah, again, rhexis. The problem is the rhexis, you need to go sometimes, you need to have a very good microscope. If you have microscopes like the Leica, the Lumira, which is very, very good, the top end microscope, that's got a fantastic retro glow or the retro illumination, which is very, very good. And even in dense cataracts and even white cataracts, you can go ahead with doing the rhexis without any problem at all. So this is a way the perfecting phacoemulsification. Sometimes you can have Synechae, and you need to open up the Synechae and make sure that you can see this is a patient who had a phaco traumatic cataract with traumatic vitreous hemorrhage as well. You can see here how I'm trying to do the open up the synecholysis and trying to do the rhexis, and this is a very mature cataract followed by waiting. Zonular weakness, pre-existing posterior capsule tear, and just to show you a subluxated cataract traumatic again combined with the vitrectomy, and just to show you that I'm doing this thing here because of lack of time, just to show you this cataract. Again, I will take only 1 minute more. You can see the lens is moving there. You can see I'm doing a rhexis and supporting the capsule, the bag with the capsular hooks, and then going out with the phacoemulsification and making sure that the bag is rinsing, and halfway through I do insert a CTR as well. Dense posterior capsular plaques, polishing the posterior capsule, removal, posterior capsular rhexis, ND YAG laser. Just to show you this one, this is a dense posterior polar plaque there. I do what is called a plaquectomy. You can see here, this is very difficult to YAG these. And this is an young patient who had a fairly dense posterior vitrectomy. You can see here how I'm trying to remove the plaque. Sometimes I use a bimanual technique. You can see that I'm using a bimanual technique to remove this. This is called the plaquectomy. You can just remove that and go ahead and implant a lens in this in this patient as well. So IOL options, always prefer an hydrophobic IOL in the bag, 3-piece IOL in the sulcus with an optic capture. And this is an optic capture. You can see if you put an optic, put the lens in the sulcus. Always make sure that you put an optic capture, capture the lens. Very, very important to capture the lens and look for the ovalization of the anterior capsule when you capture the optic with the haptic in the sulcus and the optic in the bag. And this prevents the UGH syndrome and make sure the lens is very stable. Topical steroids, anti-glaucoma medication, NSAIDs, retinal evaluation, YAG cap after 3 months if necessary. Phaco and PPVIs, higher risk, good preoperative assessment is necessary. Intraoperative protocols, very religiously. You have to follow postoperative protocols. Also, you have to follow good visual outcome in 90% of the patients, provided you follow all the protocols very, very, very strictly. Thank you very much, Manoj and the AIOC.